Hello and welcome to the Headache Doctor podcast, where on this podcast, it's our mission to educate and empower everyone with headaches and migraines so that you can break free from a life of fear of your next headache or migraine and dependence on medication. I'm Dr. Taves, your host. We have a physical location here in Colorado Springs. I'm saying this because I realize that a lot of you listeners maybe have to do some research to figure out where we're actually located. So Novera Headache Center is the actual clinic in Colorado Springs and then in Parker, Colorado. And we see people virtually through our virtual coaching process from all over to help you understand what to do to best help yourself. And then we also have the SAM device product, which we can ship pretty much anywhere. It's on Amazon in the United States. If you're outside the United States, we can probably figure out how to get it to you. Just reach out to us. On today's podcast, though, we're going to talk about the different types of headaches and how we treat them. Okay, so we're first going to look at some overarching themes. One of the things that I've noticed in these podcast episodes is the podcasts that do the best are the ones that have a specific diagnosis, and then I dive into it. And so I thought about going down the road of like a really sort of one-off diagnosis and diving into it. And instead, I thought, why don't I just talk about all the different types of diagnoses that we see and what we do to help those individuals with that diagnosis. I think it's going to be more helpful because you, the listener, are going to be able to likely hear your own story in this. I think you'll be surprised. Most people that we interact with, we start the conversation and they assume that because our healthcare system has not explained their symptoms yet, and because there hasn't been a solution, they feel like they're kind of on an island, like their scenario is unique. And so we start the conversation with, they have a sense of this is probably going to be strange or weird or abnormal, but it's rarely, if ever, in a category of headache or migraine that we haven't successfully been able to work with someone and provide them with relief. And so I'll give you sort of the main scenarios, and I hope you hear your own situation in it. Before we jump into the specific diagnoses, I want to talk about the overarching themes, okay? Now, these are themes that we've pulled out from the 6+ years of specifically treating headaches and migraines and seeing all these different types of diagnoses and then understanding that what's the common thread. So what are the common threads that underlie them that are important for you to understand, okay? So first off, and the reason that I'm starting out with these themes is because headaches and migraines can look very different. They're unique to you, your symptoms, your presentation, where the pain presents, the other types of symptoms you have, the numbness, the tingling, the aura, the visual disturbance, the fatigue, the brain fog, whatever it is, it's typically pretty unique to you. So if you use if you go around and people are saying, hey, do this, it worked for me, and you're using their set of symptoms matching yours as a way of evaluating if it'll work for you, that's going to be a little bit challenging. And so we encourage patients not to really do that. We do match people with people we've seen that are like them, but your story is unique. And so what we want to start off with is understanding that pain can't really be trusted. Okay, for example, you may have pain behind your eye. That's pretty common. Now, if pain could be trusted, then your eye would be the problem, okay? And we'd send you to an ophthalmologist or an optometrist who would then evaluate your eye, tell you why your eye hurts, and then recommend a treatment approach, okay? Now, we have very rarely, if ever, seen someone with eye pain that the eye itself was the issue. Now, there may be stress through eye muscles. There may be a lack of coordination. There may be vision therapy that can be helpful. The eyes themselves could also be unrelated. And so the pain that you're experiencing being behind your eye does not mean that the eye itself has an issue, okay? It means, so what we do with that information is say, okay, like if we've evaluated the eye and the eye's fine, then we have to look at what else can provide your brain with the experience of thinking that there's eye pain. And so we look at what's called a referral pattern. and referral patterns when it comes to the eye, which is really just anything in the head or face. Like if you have any sort of facial or head pain, the upper part of the neck can refer pain there. And the upper part of the neck, turns out, is under a lot of stress and tension throughout the day. Our heads weigh 10 to 12 pounds. It's like holding up a bowling ball, but it also needs to move quite a bit. And when we look at our lifestyle and the maybe potential like history of trauma, head or neck trauma that we've had, the combination of those two, it's likely that most people are dealing with a level of neck tension that's contributing or the underlying cause of their headache or migraine. Okay, so whether it's eye pain, pain in the temples, pain that wraps up and around, you have some weird presentation of like sharp stabbing sensations, pain in your head or your face cannot be trusted as like if you have a stab on the side of your head, that doesn't mean that specific spot on the side of your head is an issue. And most people intuitively know this, that maybe because their symptoms change or it's like, yeah, it hurts behind my eye, but it kind of hurts all over. People intuitively know like that's not necessarily the spot that's a problem. But sometimes going through the healthcare system, that may be somewhat of like a starting place. Like my eye really hurts. Maybe let's just check the eye. So we hear that all the time. The other thing that we should know as a theme is that your symptoms are controlled. Well, your symptoms are trusted in the sense that there are patterns. And for you to have pain, we want to attach that to something objective, okay? We want to attach your symptoms to some sort of actual tissue damage. So something that would cause pain in your body should be happening for you to have pain. So the location might not be able to be trusted, but we can assume that something's wrong, that your pain response is being sent to the brain, and then your brain's having to acknowledge it as like an alarm signal if something's happening that needs to be fixed, okay? We can also assume that your threshold, so your overall health, your inflammation level, things like that, are impacting your response to the pain, okay? So the intensity of the pain, the duration of the pain, even like if the location of pain is like really focal and specific to one spot, or if it's like global, those things are variable, and the threshold that you have and the level of inflammation and your gut health and hormones impact how you respond to the pain. But we can assume if you have pain, there's something physically that is causing it, okay? We also don't hold to this explanation or attempt at an explanation that migraines or any of these headache diagnoses that I'm talking about are a spontaneous neurological event, okay? I actually don't hold to any sort of head or facial pain being a spontaneous neurological event. And let me tell you why, okay? Because that means that your path to restoring or solving this problem is just leading to medication. Okay, that's it. It's also falling short of anything objective worth really treating. So, and then if you step inside the minds of our healthcare system and the providers that are coming to this conclusion, you understand that they may, in some sense, realize that the neck needs to be evaluated, but the evaluation process is an X-ray, an MRI, a CT, and it's a still image. And so what we're finding is that these are specific joints in the neck that aren't moving, that need to be evaluated and treated effectively. And the whole problem with our healthcare system is that no one's doing that. So if we don't understand how to evaluate the neck in the first place, we can't assume that these people that are coming up with the explanation for a migraine have really covered their bases. So if we search for the thing that's objectively causing pain to be referred to your head or your face, and we know that the neck, we know it's well studied, documented, that the neck refers pain to the head or the face and can cause these symptoms. Okay, well, basically they're zooming past the neck after the CT or the MRI, where we're finding these problems over and over and over again, basically in everyone that has these issues. And so it's based on experience, and then based on the understanding of like, okay, what is our healthcare system doing? What are the neurologists doing to get to that conclusion? And then understanding there's gaps in their process to get there, okay? So you want that to be true too. I mean, you as a listener with headaches or migraines, you want it to be true that it's not just a spontaneous neurological event, because I wouldn't have a job and you would just be stuck taking meds, basically managing the intensity and the frequency. That's it. So there would be no reason for me to do this podcast if there was sort of a scenario where like, oh, this is just like my diagnosis, I'm attached to this kind of forever and I'm just going to take meds. So we're also not talking about like that being a category and we're just working with like the neck problem that's associated with it. No, that's not what's happening here. We're talking about all of it. Okay, so any sort of head or facial pain, whether it's like a debilitating migraine, a daily headache, sharp stabbing pain in the side of your head, a tension type headache that wraps around as like a band in your forehead, all of that stuff, okay? We're talking about the underlying problem that we can fix, okay? So it's not as if like someone comes to us, and this is one of the types that we treat. It's called the 2 types of headaches. It's like, hey, I have a headache that feels more connected to my neck, and it's more frequent and it's lower grade. But then every now and then I have this migraine. And so I know that you can help with the neck problem, but you know, the migraine's something else. Like, no. They're the same underlying problem. You're just experiencing it differently. Okay. So sometimes at less frequent times, you have more intense, like pounding, throbbing, one-sided debilitating pain. And then you feel that same tension that's there at a lower grade more frequently, and it just happens that you feel your brain is more aware of the neck tension during those times, okay? And again, based on experience and historically, like both are treated effectively. It's not like we're treating one headache and ignoring the other because that's different. That just needs medication. That's not how we operate because that's not what we see. And again, you want that to be true. You want that you want everything to have something objective that's underlying, that makes sense of it. And so here we go. Let's dive into the different types of diagnoses. So we have cervicogenic headache. This is the, okay, I could go, this podcast could be like an hour long, but I'll try to keep it short. So cervicogenic headache is really just a headache that comes from the neck. Okay. Now this, I could argue, is like pretty much all of the people we see have neck issues and they have headaches. So by its broad definition, like cervico means neck, genic means the origin. So neck origin. Now we're working on the neck with pretty much everyone. They all have different types of headaches or migraines. So we could argue like all of the different types have cervicogenic possibilities. What it's intended to mean is a very clear, like you turn your head or like you have pain in your neck and it shoots up and around and it's one-sided. So that, like in the medical world, that would be like, oh, you have a cervicogenic headache. Like if a provider has you like turn your head or you say your neck's really stiff and then it starts there and wraps up and around, they'd say, okay, that's a pretty clear cervicogenic headache. Now those are the sort of low-hanging fruit. Those seem to respond super well. It's like there's a mechanical problem, there's a joint that's irritated, its irritation builds, it shoots up into the forehead, wraps up and around, and we get the joint moving, reduce stress to the neck, and it goes away. So those are like really straightforward, respond really well to hands-on techniques, are usually like up and to the right as far as progress. I mean, there may be a little bit of up and down depending on like person's lifestyle or like, you know, if they went on vacation in between appointments, stuff like that. But ultimately, if someone is compliant, willing to change, make lifestyle changes, like the treatment itself is pretty smooth. Then we have tension type headache. So tension type headache would be like that band or strap in the forehead. Generally, tension type headache is there because you are literally carrying like tension on both sides, through the shoulders, through the neck, and your neck and shoulders are just kind of stressed out. There's a level of like attention we need to give to muscle and shoulder function. Typically the shoulders are a little bit more of a focus. You're going to have the neck joint issues as well. Generally the neck joint issues are there, like your neck is sort of stuck in a forward head position, maybe tilted one side or the other. And it's that resting posture that the rest of the neck and the shoulders have to kind of like respond to and try really hard to hold up your head throughout the day. Tension type headaches also typically onset like in the afternoon, evening. So there's a lot of like behavior, lifestyle type changes that we're working with tension type headaches. A lot of it is patients making changes on their own, accompanied with us working in person on them, or if we're coaching, like tension type headaches, again, are like, let's make these lifestyle changes, because we know that the amount of stress you're taking on throughout the day is increasing the amount of tension. So if we change that equation and move the variables so it's more therapeutic, we get the relief. Okay, then we have like true migraine, right? Like, oh, you have the migraine diagnosis. You have a pounding, throbbing, one-sided, debilitating pain accompanied by nausea, lighter sound sensitivities, maybe an aura. And you've received this diagnosis based on those symptoms. So just real quick, the migraine diagnosis gives you nothing objective to treat. It basically just says, like, you have these symptoms, we're going to repackage it into this diagnosis of migraine, and then here's a medication to try, usually a triptan or something like that. But migraines, I think the most common diagnosis that we see here, and the most common diagnosis that we see improve, right? So like all of these different types we've seen improvement with, but migraine is very similar to cervicogenic headache. Typically migraine is just like maybe a little worse, and then also has like the nausea, vomiting, light sound sensitivities, maybe an aura, so those other things. Now, those other things are just sort of telling us that the pain signal that the brain's getting is really intense. And so it's sort of like the brain is sort of stressed out trying to figure out what's happening. And then the alarm bells are going off. And the alarm bells going off sort of sensitize all these other sensory inputs so that you have like light and sound sensitivity. It's like your brain just can't really handle like harsh lights, harsh sounds, harsh smells, things like that. And so the migraine is a more intense pain, is more debilitating, accompanied by those other symptoms. But it doesn't mean it's not a neck issue. It's just like a really loud, annoying neck problem. Okay. So very similar in like there's going to be a joint issue. Obviously, we're working on lifestyle changes, things like that. But yeah, again, if you have like a one-sided pain, that is usually corresponding to a specific thing in the neck, like a joint on that same side that's really angry. And once we start addressing that, improving it, the migraine frequency intensity drops substantially. Okay, we talked about the two types of headaches. We also have like new daily persistent headaches or daily persistent headaches. So think of this as the person that's had neck tension and like a neck issue, maybe infrequent headaches or like relatively frequent headaches for a while. They don't even have to have a history of headaches. Sometimes it's just like out of nowhere. We typically see that in like our middle school, high school patients, but it's going to be like you woke up and you have a headache and it never goes away. Now, what happens here is the body is able to compensate relatively well for a period of time. Like the headaches aren't a big deal. And then something happens. Like it could be something as little as like you slept funny, or you traveled and you slept in a different bed, or like you flew on a plane and the pressure in the cabin, or something impacts your neck in a way that like pushes it over the edge and you just can't get out of it. So it's like you always have a headache all the time. And it has to do more with like, you know, the boiling pot was just like, it was boiling at its threshold for so long. It was just kind of ready to go. And the brain was trying to calm it down, ignore it in a sense. And then, just one little thing tipped it over the edge. And now you're in a state of like constant daily headache. Now the brain was so fatigued from trying to like stifle everything that now it's just sort of given up. It's like, I'm not even going to try to hide this anymore. Like we're just always going to be in pain. And it can be like really bad, like 9 out of 10 pain. It can be, just like a 2 or a 3. But typically it's always there. It doesn't really go away. Now with daily persistent headaches, it is the mechanical stuff. Like we're working on the neck, we're making lifestyle changes to create an environment for the brain to calm down. But we do need the brain to calm down. And that's where it's less of like a immediate response. I have had an immediate response a few times, but usually it takes time. So it's not like the cervicogenic headache that like we get the joint to move and you like feel better walking out of here. It's typically we just have to work on the things we find, and then maybe like weeks go by or a month goes by and you start to see the improvement. But you have to just understand that like the pain is coming from somewhere. The brain in that scenario is more involved and like hypersensitive. And so treat the thing that's causing the pain, but don't expect the result as quickly just because that daily pain changes how we interact with the pain signal itself. We've got TMJ related headaches. This is like potentially in the morning when you wake up, if you have sleep apnea, if you're grinding, clenching your teeth at night. You'll wake up and like maybe your jaw pops or clicks, like not necessarily in the morning, but just in general, you've known that you've had jaw tension or issues. The pain might be more temple related or in the jaw or in your teeth, and potentially one-sided. You probably also have like neck and shoulder tension as well. With these headaches, we are going to take the same approach of working on the neck, because that's kind of at the foundation of this. I mean, if your neck's tight, if it's tipped to one side, that's going to impact how your jaw functions. But we're also going to look at your jaw. Okay. Alarm clock headaches. These are like, they wake you up at 3 a.m. Every morning. So yeah, these are very disruptive to life. And oftentimes we find these in our like maybe 60 plus year old patients. Have definitely had them in younger patients, but it's something that can be like new. Someone's in their like 60s and they're like, man, I'm waking up with these headaches. So we look at sleep position, we look at airway, and we look at the amount of tension that you're carrying at night. And then, so very similar in like looking at restoring mobility in the neck, the specific joints in the neck. But it's going to be a little bit more focused on like sleep position, making sure that looks well, and your sleep hygiene and the amount of tension you're carrying into bed looks like what it should. And then we have like hormonal migraines. See that all the time. We're not doing anything with hormones. We're maybe referring out to a provider that can really help with balancing hormones, but ultimately the pain has to come from somewhere. And like estrogen levels aren't like directly causing like your right eye to hurt. And so we look at what is causing the pain itself, which is generally a neck issue again, okay? You're just impacted monthly by the fluctuation of estrogen levels that impact your threshold for tolerating that, okay? So we have both things. We have the thing that's causing your symptoms, and then we have the thing that's impacting your threshold. So like I said, one of the principles in this scenario, we have to understand, like, just because it's hormonally related doesn't mean hormones are the problem itself. Something physically is causing your body to experience pain. And then we have like ice pick headaches and cluster headaches. So ice pick headaches could also be like trigeminal neuralgia or occipital neuralgia, like this sharp stabbing, burning, like really intense pain. Sometimes it's like behind the eye or in the temple. And so these headaches, we see really good responses with these as well. Think of this as like if the tension headache is like a bunch of stuff feels off at a low grade and it just like a band in the forehead, like the pain isn't descript, it's just sort of general pain. The ice pick headache is the opposite of that. Like it's a very specific spot, even it can move, but it's a very specific spot. And that usually coordinates it usually corresponds to a very specific spot in the neck as well. And it's usually like the second and third vertebrae. And it's a really sensitive area that like, as the tension builds, it's like that joint gets angry and your brain thinks like there's a sharp stabbing sensation somewhere in your head. And so again, we get good responses from that because if we fix the mechanical issue, if we fix the joint, if the joint starts moving, the ice pick headaches start to decrease. And then we have cluster headaches. Cluster headaches are headaches that can like be gone for like months and then come back for a period of time, cause like kind of interesting symptoms like tearing or eye redness or inflammation. And it can be really, really intense. Sometimes they're like really short-lived, like 30 seconds or so. I've had several scenarios of like different types of cluster headaches, and and most all have responded well because we find the problem again in their neck, and everyone has like a rhythm their body can go through where they're healthy, they're feeling well, there's no symptoms. It's not as if the neck problem went away, but they might go like 3 months on this like sort of cycle of feeling good. And then that tension over that time is building until it like hits that tipping point. And then you just feel it and it's terrible. And it's like debilitating, maybe for like a week. And then you get out of that and then you're sort of living your life not knowing when it's going to happen again. It could be like 6 months or 3 months. And so cluster headaches are really interesting. I explain that based on like what your threshold is, what your body's able to tolerate, what you're able to ignore, and then sort of that tension building up over time. you reach this sort of tipping point and then it resets. Okay. So just an interesting cycle of like similar problem. The way you experience it is different. But again, have had success in taking our principles, applying them to that, that specific diagnosis. Okay. So your takeaways here, even if you didn't hear your specific like diagnosis or pain pattern, know that this isn't like an all-encompassing list, but your takeaway here is that we want to look for something objective. We want to fix the thing that's causing the pain. We don't want to assume that like your triggers are the underlying cause, but are contributing to your threshold, and that your diagnosis is not something that you have to live with like a pet for the rest of your life. And it doesn't mean that you have to take medication to just manage it. We want to find the thing that's causing the problem. We want to fix that. That's what we're all about here at Novera Headache Center and on the Headache Doctor podcast. And I appreciate you all listening each and every week to the Headache Doctor podcast as we continue on our mission to educate and empower everyone with headaches and migraines so that they can break free from a life of fear of their next headache or migraine and dependence on medication. I'll see you next week.